Good evening, everyone, and welcome to OCULUS Keratograph 5M Elevate Your Dry Eye Clinic with Dr. Rolando Toyos, MD. Before we get started tonight, I just wanted to make sure that all of you know we are going to be doing questions at the end. So go ahead and submit your questions as soon as you have them, and we'll take that time to address them. Secondly, there will be a recording of this. That way, if you miss anything, your internet goes out, what have you, you can see that recording after the fact. And a few days after that, it will be put up on our YouTube channel for you to view. All right, I'm very excited for tonight's talk. Dr. Toyos is the founder and CEO of the Toyos Clinic, which has offices in Memphis, Nashville, and New York City, and South Haven. The clinic is heading into its 25th year, and Dr. Toyos is not only a specialist in LASIK and cataract surgery, but also a dry eye specialist as well. And so many of the times that we talk about dry eye, we get the optometrist perspective. I'm really looking forward to the perspective of an ophthalmologist. Dr. Toyos, take it away.
Great. Hey, it's an exciting night for me. Not only do I get to talk about dry eye, but right after this, the Memphis Grizzlies are playing in a playoff game. So I'm going to leave here, go across the street, and watch the Grizz play. I took care of the team for 10 years and a lot of different teams. And in the spirit of talking about dry eye, this is Jean Morant giving this player who has dry eye his version of a warm compress. I also wrote a book about my times as a sports ophthalmologist, the life and times of a sports ophthalmologist. So I've been given free rein here in talking about the keratograph and dry eye. So before we get into the keratograph, I wanted to just talk about what are the things that I have done to make dry eye clinics successful. I've been able to set up dry eye clinics in New York City, Miami, LA, and then in our own clinics in Tennessee and in Mississippi. So the first thing, and this all kind of relates to the keratograph, is you really have to manage your time wisely. And why is that? Because I always tell people who are getting into dry eyes, you've got to slow down. You've got to take your time with the patient. So this isn't a quick glaucoma check where you're checking the pressure, saying, okay, Mrs. Jones, pressures are good, and here are the drops that we're going to use, or here's other options that you have. The dry eye patient, you've got to slow down because there's a lot of factors that are going into treating the dry eye patient. I always tell people that you have to be part immunologist, part allergist, part psychologist, part dermatologist, because this is a skin gland condition that is, for the most part, affecting the eyes. So you really have to find ways to be efficient with your time so that you can devote more time to listening to the patient, letting them talk about their disease, letting them talk about all the different types of treatments that they've had in the past. So you have to find time in other ways. So really you have to utilize your techs in everything that they can do to help you, so you're not bogging yourself down with tasks that could be really handled by somebody else. Then you have to have a systematic approach to treatment. You've got to say, okay, if I have this type of patient, this is how we're going to treat them. If I have a Sjogren's patient, this is how I'm going to treat a Sjogren's patient. If I have a meibomian gland dysfunction patient, this is how I'm going to treat a meibomian gland dysfunction patient. If I have a mild problem versus moderate versus severe. So what are your steps? Be very systematic in your approach. Some of the mistakes that I've seen is a patient comes in and a doctor will throw 8 or 9 different things at them. And that's not very systematic. I like to actually try one thing, see how the patient responds to that, and then add on accordingly. You've got to eliminate old world thinking in terms of dry eye disease treatments. It took me about 20 years to convince doctors that intense pulse light was a treatment. And I think that was because they already had in their mind, this is the way you treat dry eye: warm compresses, lid scrubs, and artificial tears. We don't want to hear about anything else. And in the beginning, I've been doing this now for dry eye for over 20 years. We didn't even have Restasis at the time. We were actually mixing our own cyclosporin with a pharmacy doing it for us. Then the other common mistake is, since you've been doing eyes for how many years you've been doing it, you think that, well, shoot, I've been looking at eyes for 10 years, 5 years, 15 years. I'm an expert already looking at eyes. I think dry eye disease is its own subspecialty, and you have to do the Malcolm Gladwell 10,000 hour rule, where it takes 10,000 hours of doing something to really be an expert at it. Open your mind to new treatments, as I was talking about before. And I think accessibility is very important. When I was talking about being part psychologist, a lot of these patients are in that chronic pain spiral of depression, where they're have been suffering from this for so long that they're trying to reach out to people, whether it's supports people on like a Facebook or friends, but they're also trying to communicate with their doctor. So I say be as accessible to your patients as you possibly can. So one thing that I actually do is I let patients text me, and doctors always go, well, wow, that must take up a lot of your time. And I've actually found that it's actually saving time, because if a patient has a quick question, I can answer it quickly in a text. But if they call the office, that front office person talks to a tech gets a message, then the message comes to me, and then you're going back to the tech, and then the tech's talking to the patient. When most of the time these questions can be answered very quickly. Now, if they have a longer question that's more detailed and more personal, then I tell the patient that we can discuss it more when they come in for their exam. But don't be afraid to be accessible. So with the Keratograph 5M, now I was actually kind of looking back and seeing how many years have I been working with the Keratograph 5M and OCULUS, and it's getting over 15 years. And I actually pulled out a lecture and I put it on social media that I did on IPL and looking at non-invasive tear breakup time with the Keratograph, which I presented way back in 2011 at ESCRA. So I actually have a lot of experience using the Keratograph, and I've gone through a lot of evolution in terms of how I use this in the clinic to be as effective as I possibly can. But it does a lot of things: tear film quality, quantity, meibomian gland assessment, redness, lid imaging, fluorescein imaging. Don't forget it's a topographer as well. In our dry eye clinic, we utilize the 5M to accumulate objective information before I even walk into the room to see the patient. I'm handed the information that we attained with the Keratograph, and it gives me an idea of what I'm walking into before I sit down and listen to the patient. And that actually helps focus me into what I'm going to be talking to this patient about and how we're going to treat them. I also use it to measure progress. So we always do, if it's a first-time patient, we always do a couple of the exams on the Keratograph to keep in their record. And I don't serially, so say, for example, let's say IPL, which is my protocol is usually a 4-treatment protocol. I don't do a Keratograph every time the patient comes in for their IPL. I will usually do an IPL before their first treatment, looking for dropout, looking for abnormal meibomian glands. And then do a series of treatments, and then at a later date, I will go ahead and do another mybography. Why is that important? Because sometimes the over-testing can really hurt your dry eye clinic and bog it down. The other thing is you're setting yourself up for failure in the patient's eyes. If you get a initial mybography and then you keep getting mybographies, I can tell you whatever treatment you're doing, meibomian gland dropout will not come back after 1 or 2 treatments. So myself and Dr. Arita out of Japan showed mybography before IPLs and mybography after IPLs, and things like dropout usually take at least 4 treatments of IPL and sometimes even more to see those dropped out glands coming back. So, set yourself up for success. Don't set the patient up for failure if they keep asking you. A lot of patients come in and say, what's my tear breakup time this time? What's my tear breakup time this time? I said, look, here's your initial tear breakup time. We're going to go through a series of treatments or however we're treating you with drops, with other things. And then after months, we can go ahead and retest and see where we're at, so we get a good picture of how our treatment is working. And then I use pictures and data to educate. I think, and I'm going to show you the things that we have as our go-to for Keratograph. It's great to be able to show the patient images, say, look, these are your meibomian glands. This is what normal should look like. Here is what your glands look like. You want to know how red your eye is? Here is how red it is in this scale. So yes, you do have a red eye, and let's do some treatments and see what happens to that red eye after we decrease the inflammation to your eye. So I use the pictures to educate and the data to educate as well. So there's a bunch of different illumination systems that you get with the Oculus, including blue, white LED, infrared, and that's how we're able to do all these different images. And it's on a Placido ring, which you're familiar with when we're talking about topography. So this is a very important slide to me because I can't tell you how many keratographs and dry eye disease measuring devices have come our way to our clinic, where companies will come by and say, hey, can you take a look at our mybographer or our imaging device? And I like the fact that you can actually expand the field with the Keratograph 5M. So the mybography is of the full lid, not just a portion of the lid, but you can get a full lid and get a good picture. And then when we get into, I'm going to show you some pictures of patients of mine. You can see what an advantage that is. Instead of just getting a small little window into what the patient is going through, you can give them the big view and say, look, these are all your meibomian glands in the lower lid, and here are all the meibomian glands in the upper lid. These 3 here are normal, these 2 here are abnormal. You have dropout here, and these 2 in this area here where 2 glands should be. And you can just go down the line and be very and educate the patient. So, you come in, I'm not going to spend a lot of time on this, but you can see looking at the left-hand side, once you put a new patient, all the different things that you can do with the patient. You just would click that. So you'd click, non-invasive tear breakup time, and that will come up, and then you do your test. Okay, where do I begin? So here I just gave you that long list of things that you can do. So in the beginning, when I first got my Keratograph, I would do all of those things. And what it did is it gave me some knowledge. So this is, if you're getting the Keratograph for the first time, go ahead and play with it. Have your new patients do several of these things. This will help you accumulate your 10,000 hours, and it'll give you an idea of what's normal and what's abnormal. I did tests where we were just looking at everybody to look at their meibomian glands and what their meibomian glands look like. And I can actually, I'll go over some of the things that we found in some patients who said they were asymptomatic and had no problems. Our clinic is busy, so I prioritize what info I have. So I was told in this lecture to lecture on what we actually do. So here's where I've evolved to in using the Keratograph. Here are the things that are important, that I feel are important for me. I think my biography is the #1 thing that I rely on when I'm using my Keratograph. Non-invasive tear breakup time. That actually takes tear breakup time, which will take time out of your exam of the patient. Here's something the tech can do the mybiography, and they give you information. The tech can do the non-invasive tear breakup time, and that will take away the use of you using fluorescein. I actually only use fluorescein now if we're doing a study. I actually rely on lissamine green as actually my stain of choice. I think it gives me a lot more information than fluorescein. The tear meniscus is important. You have a lot of patients that wonder, do I have Sjogren's? Do I have a water problem? And looking at the tear meniscus at the slit lamp and also with the Keratograph really tells me if we can eliminate kind of Sjogren's. I don't actually do Schirmer's anymore. I actually look at the tear meniscus to give me information on whether the patient has a lacrimal gland problem. Bulbar redness, I use that, especially in patients whose main complaint is redness. But the most underdiagnosed thing that I've seen in my dry eye clinic from referrals from other doctors and from patients who have come to me after they've seen other doctors is conjunctival chalasis. And we'll get into that later on. But this is actually a great system to use to look at that conjunctival chalasis. We actually, my wife and I, Melissa Toyos, who runs our research department, we actually did a study where we looked at, could Lumify help mild conjunctival chalasis? And we use Lumify and brimonidine to actually, what we found is not only does it close off or constrict those blood vessels, but it actually will tighten up the conj in patients who have mild conjunctivitis with mild chalasis, and we showed this in our ARVO paper. And then lid picks, very important. So lid picks are great to show patients because patients will come in and ask you, do I have Demodex? I was reading about this Demodex. Do I have blepharitis? These lid picks are great to show the patient. One of the things that it's really great at showing at is you have a lot of patients who have rosacea. Now they don't have a 10 plus rosacea on a 1 to 10 scale where they've got the bulbous nose and blood vessels everywhere, they're red as can be. But a lot of patients who have meibomian gland dysfunction have +2 to 3 rosacea, and you can see those telangiectasias on the thinnest skin of the face, which is right here on the lid margin. And you can show them, you can go, look, this is rosacea. Rosacea's telangiectasias in the epidermis. We're not seeing that here at other places of your face, but since we're looking at the thinnest skin of your lid margin, we can actually see these telangiectasias, and we know that over 80% of patients who have some form of rosacea will have meibomian gland dysfunction. And then, as I was saying before, I won't take these pictures until after the patient has undergone treatment. And there's a ton of treatments. I'm not going to get into them because it's not part of the lecture, but read up on Optilite and IPL, the Q, which is low-level light treatment, Optimal, platelet-rich plasma drops, Cequa, Tyrvaya, Oxervate, low-dose naltrexone. All of these I've done lectures on and I've put on YouTube, and these things are a lot of our kind of standard treatments for treating these dry eye patients. All right, so this is a true Oculus story, and this goes to the accessibility portion. So I will get patients who will email me, or they'll get my phone number and text me, and these are new patients or patients people I've never seen before. So just last week I was at Ascaris, and this patient found out I was going to be in Washington, D.C., and he's in Washington, D.C., and he said, hey, can we meet up? I'd like to talk to you about my dry eye. I got him on the floor, went straight to the Oculus booth, and I heard his story, and then I wanted some information on him. So we went here, and this is pretty easy to use. Right on the Ascaris floor, I got some mybography on this patient, so I got some information on what his meibomian glands looked like, with some mild abnormalities, some dropout, some problems in that lower lid. But the main thing for him is, look, this patient has telangiectasias. You could see them in these pictures that we were taking of his lid. And then after that, I went ahead and did the Q, which is our low-level light treatment, which is red. This one's red. This one is blue, where you're putting low-level light treatment right on the meibomian glands. And this is, I have the patents for light treatments for dry eye, including low-level light treatment. And then I took him over to another booth, the Luminous booth, and I used the digital trio to go ahead and express his glands. And if you haven't seen this for me is the best expressor ever. And I have no financial tie to it. It's the OCULUS LidStick, which you can get on oculus.com. And it's actually a silicone tip. So here the silicone tip is used to go ahead and get the mybography, and then it has this little plank spatula on the other side of this lid stick, so that you can actually flip the upper lid over. That's my thumb here. So we flip the lid with this upper little spatula, with the spatula here, to get mybography of the upper lid. But this silicone tip allows me to do expression after I do something like low-level light treatment or Optilight or IPL. So that silicone tip goes on the lid conjunctiva, then my finger on the other lid, and what we're doing is we're applying pressure at the base of the meibomian gland. If you haven't read my blog on the physics of expression, you should. This is non-Newtonian physics, where, just like a tube of toothpaste, with increased pressure using the Oculus LidStick, you will get a decrease in the viscosity over time of this toothpaste-like meibum, which will allow more meibum to go out. So the best way to express a gland is constant pressure. Just leave it there. That will lower the viscosity, and then over a course of time, you'll get more and more of these secretions out. I'm not into lid expressors. I feel like they're just squeezing right in the middle. They're not. You can't get a lid expressor low enough to do this squeeze and a constant squeeze at the base of the meibomian gland. So that blog is available on the blog spot on toyosclinic.com. So that's my true Oculus story. Oh. And then, you can grade these meibomian glands. I don't do the grading system. I've got the pictures right there, but I can show the patient glands that are dropped out, glands that are abnormal. So mybography, I love it. I love doing mybography. Patients get shocked. This is the face of my patients when I show them, hey, this is what normal looks like. Here's what yours looks like. This is one of my patients. And you can see how the glands, it's not as neat as that grading system as you see there. This is abnormality. Instead of a nice straight gland, one way that you can tell abnormality is the gland will start to get these weird tortuosities. They'll get some dropout. They'll start to lose. Here you get some dropout, and you can see that. So you show these patients the really abnormal sausaging instead of a nice straight gland. So this is one of the reasons why I'm not a big proponent on probing. without visualization, which I don't know if anybody's doing probing with visualization, but what we're getting in our clinic is a rash of patients who are getting probed, and actually their glands are being dissected. So this is a perfect example of that. This is a patient post-probing who came to me with problems. These are actually little blood clots from where the gland was transected, and you can really see that on my biography, where maybe these glands were going to the right or to the left. You tried probing and you dissected that gland, leaving these little black spots where blood will accumulate where you've injured the gland. So not a big fan of probing. I have several. This is not just one patient. I have several patients of that. So if you ever look at a lid and you see these black spots there, just ask them if they've ever been probed. All right, so here is actually my 20-year-old tech, and we were doing my biography on normals just to see what we were getting. This was her, and you can already see that she's got, this is the top lid, abnormality in her meibomian gland. This is in the patient who's the 20. So this shows you dry eye, and then when she was asked about dry eye problems, she was going, yeah, I do have some, and these are the situations that my eye get dry. And so she definitely has some meibomian gland dysfunction. So, now we're getting teenagers, 10-year-olds with meibomian gland dysfunction. Usually those really young patients have like an acne or an acne rosacea that's causing it. But once you get this, it's great to do not just patients who are coming for dry eye, but getting a catalog in your mind of what looks normal and what looks abnormal. And I think you're going to be surprised at how many patients do have meibomian gland dysfunction and maybe are asymptomatic now, but over time, they will become symptomatic. So ocular surface assessment, like I said, the lipid layer, usually that's something that I look at on the slit lamp, the same with tear film dynamic. But the non-invasive tear breakup time, this is something that I've been doing for years. One of the things that I showed and kind of working with OCULUS several years ago, we were trying to figure out if we can redesign the program in a way. But what I find with the non-invasive tear breakup time, I usually add about 2 seconds to the measurement that I get off the non-invasive tear breakup time. That's really a good kind of hard rule so that when you're looking at these non-invasive tear breakup times off the 5M, if it shows you a 2-second T-butt, probably if you did a floor scene, that patient's going to be 4 seconds. So this is something that I did several times because we were trying to make this as maybe a standard for different studies to do non-invasive tear breakup time. But the main thing is this is something a tech can do. It's going to save you a lot of time, and it'll give you something objective to follow the patient when it comes to meibomian gland dysfunction and tear breakup time. And so you can actually follow this patient as they go through the treatment and see that improvement. The reason why it's so sensitive and the numbers are lower is that it will spot any kind of disruption on that corneal topography layer and the placido ring. So very more sensitive than what we're looking at in the slit lamp, where we're looking for a spot that starts to break up and then expands on breakup. That's usually what we call a tear breakup time, or what doctors call a tear breakup time, whereas these are a little bit more sensitive, so any disruption in the placido ring is seen as the start of a breakup. But again, very helpful information, and it was something that the text can document, give to you, and that you could use right away in terms of following these patients and assessing how bad their tear breakup time is. And this is a study that I was telling you about that I found. This was a prospective study of the effects of intense pulse light on dry eye syndrome as measured by Keratograph. So this is back in the day when I was trying to get this as more as a standard. The reason being is there was a study out of Japan where they got several doctors in to look at tear breakup time, and what they found is tear breakup time is a plus minus 2 when doctors are looking at it. So it's not as objective as you think. It's a little bit subjective. So we're thinking this might be a more objective way of looking at tear breakup time for efficacy in a treatment. And for our study, we showed that these patients who came in with less than 2 seconds of a tear breakup time improved to just a little less than 6 seconds of tear breakup time. So in my hard and fast rule, this was probably looking at fluorescein tear breakup time. These patients were probably under 4 and improved to about 9 or 10 when you added, or about 8 when you look and apply that rule. And then the tear meniscus, I think this is a very important way when patients ask, hey, do I have Sjogren's? It's amazing how many dry eye patients feel that they have Sjogren's. And as Penny Asball showed in her study, there's the percentage of dry eye patients coming into a clinic with Sjogren's is very low, less than 10%. So, but this is a good way to look at it, which brings me to another thing, plugging. You know, a lot of patients are plugged, and for me, not a big part of my regimen in treating these dry eye, but this can also tell you is if the patient is going to benefit from plugging. If they don't have any tear meniscus, if their tear meniscus is less than a 0.35, then they may have a water problem and plugging may help. But again, for me, I would put in a dissolvable plug first before you put in a permanent plug on these patients. Lipid layer, it can scan this. This isn't something that I use, and because in the slit lamp, this is something that I'm using in the slit lamp, looking at the color changes, the birefringence of the lipid layer to tell me how good or bad their lipid layer is. But in the beginning, this is a good way when you're first starting out the Keratograph to take some pictures and see what's normal and what's abnormal. And again, thin and white, abnormal as you get into more of the colors of Roy G. Biv, you're getting closer to a more lipid in that tear film. So here's a thick layer. You can see the different colors on that lipid layer. Good tear meniscus. Placido rings look nice and clear. It's almost like putting a little bit of soap on the top of water and seeing that kind of layer above the water. And there you can get a little video on this blank. I don't think that's going to work. We'll go to the next. So here, not as great of a lipid layer. You're seeing more brown and yellow instead of blue. And then here is a completely abnormal lipid layer. And here you can see this saponification at the lid margin. The Placido rings look terrible. No lipid in this. So this is what I do at the slit lamp. I've seen this for years and years and years. I get a pretty good idea of what their lipid layer looks like in the slit lamp. But when you're starting out, you got that Keratograph 5M. You can use that to kind of help you get to the part where you're so experienced that this is something that you can do at the slit lamp. Conjunctival redness, I can't tell you how many patients say that the number one thing that bothers them about their dry eye is redness. Another interesting fact is men are more, when you can have a guy with terrible meibomian gland dysfunction, dry eye. The thing that bothers them the most is the redness. I had a high up person in this public company whose dry eye was affecting him so much. He had this redness, and he would walk into meetings, and people would always say, did you have a rough night? Are you smoking marijuana? So this can affect people professionally. So redness is important to them. It's important to document and then show them that it's improving as their meibomian gland dysfunction or their lacrimal gland problem is improving and their tear film is improving. And then this can give you a scale of redness. And again, you can tell the patient, look, you're at a 4. Now that you've been getting treatments, this has gone down. Like I said, lissamine green is now a staple in our dry eye clinic. I just think it gives you so much information. And every study that we do now, and we've got about 6 dry eye studies going on right now. Fluorescein is used for the cornea, but lissamine green is used for status of the conjunctiva. And now we're looking at more than ever before in studies looking at the conjunctiva and how dry eye is affecting it. And then you could do fluorescein imaging as well. And this is something good to take a picture of, and you can show the patient these dry spots on their cornea, and this is one of the reasons why they feel so much irritation. Okay, imaging, this is what I like. I like imaging the lids. These are the 2 pictures that came with this slide, but I actually like giving you real world. This is a patient came in just really inflamed eyes. This is what she looked like. But here, this conjunctivasis, the conjunctiva just kind of flopping over the lid margin. Every time she's blinking on conjunctiva. And then look, and these are all pictures you can take with the Keratograph, just showing, hey, look, your meibomian glands usually make a clear oil. Your meibomian glands, are shown here with just white spots because you have toothpaste clogging up the glands. Again, conjunctivasis, it is the most missed diagnosis in a lot of these dry eye patients. Here's a patient on blinking. Here's the conj. It's flopping over the lid margin. Every time she's blinking on conjunctiva. This is causing pain and irritation. The glands, when she's blinking, aren't being expressed because she's blinking on conjunctiva. So this is something that needs to be documented, and you can document that on the Keratograph. The other thing you can document is a lot of patients want to know if they have Demodex and blepharitis. So here you see the collarettes, the scurf, good telltale signs of Demodex infestation. You don't really have to pluck this to look at the Demodex. Each Demodex has 6 eggs in it, so you can see where if Demodex isn't treated, that this can overgrow very quickly. Pupillometry. So it has pupillometry. This isn't something we use in our dry eye clinic, but I think this is pretty interesting. Years ago, as being part, I was doing a study using the Keratograph and the pupillometry, where we were looking at if this would be a way to study concussion. So basically, the patients would come in, the football players would come in, we would do pupillometry with baseline pupillometry after exercise, so that we would have a baseline. It would be stored in the Keratograph. And then if they were hit on the field, they would come off the field. And then we would look at pupillometry again. seeing if there was a slowdown in the constriction, and that is one of the telltale signs of a concussion. I actually presented our data to the NFL concussion group that they had, and a doctor came up to me and said, this is great, but I never see this happening. The last thing that the NFL wants is an objective way of telling somebody has a concussion. We actually would rather leave it a little bit more subjective, and I think it was because players would be pulled out. Funny story on when we did this with a high school player had gotten hit. They were in the playoffs. We said, hey, come over to the side, but he didn't want to get taken out of the game, and so he kind of hid away from us. We tried to find him after the game. He's still hiding away from us. So there are objective ways to look at concussion in players, but are they going to do it? And then you're going to get a lot of different keratographs coming. I don't know if you recognize this guy, but he kind of sort of looks like the GOAT, Tom Brady, but he's not really. So not all keratographs are Super Bowl ready. You're going to get a lot of keratographs that'll come by and say, hey, we can do this, this, and this, like the 5M. But what I found is when you get right down to it, they're not the same thing. So I wrote a book on dry eye disease that I wrote 10 years ago, and dry eye disease treatment in the year 2020, looking at the future of what dry eye treatments would be. I thought 2020 would be a great year. But if you want a good primer on how we treat dry eye, this is a good book for doctors. It's also a good book for patients. All proceeds go to free care to the uninsured and needy. We have a New York City dry eye clinic on Saturdays. We have a lot of doctors that fly in and spend the day with us on a Saturday. Just call Nikki at this number to set that up if you ever want to see how we run our dry eye clinic. And then we have a TAD conference. We just had one during Vision Expo. We're going to have another one at Vision Expo West. So it's a Friday night lecture. We split up the group into 2 groups, and then we do morning where we have lectures. TAD stands for technology, aesthetics, and dry eye. So you get, my wife talks about different technologies on the aesthetic side, and I talk about all the technologies and things that we do on the dry eye side. So Friday night we do a lecture. Saturday we have doctors come in and staff, whoever wants to attend, even industry, and we go over all the different treatments, and then we show them the treatments. We actually have patients come in and we show all the different treatments that we do. And then Saturday night we have a lecture. So kind of worked really well with Vision Expo because doctors can come in, get a little bit of specific dry eye education, and then get back to Vision Expo and do what they were doing at Vision Expo. So we're going to try it at Vision Expo West. So if that's something you're interested in, you can also call Nikki in our clinic to sign up for that. That's it. So I decided to leave some time for questions, and I will take them now.
Perfect. Thank you for that wonderful presentation. I highly recommend everyone, reading those books, looking at those resources. And just a reminder to everyone, this is being recorded. If you missed anything, you can go ahead and check out the recording that you'll be emailed in about 2 days. And then a few days after that, it'll be up on our YouTube channel. And if you have any questions you haven't asked yet, go ahead and put those in the chat now, and we'll go ahead and get those answered tonight. All right, to get started, it's often said that an ounce of prevention is worth a pound of treatment. What are the ounces of prevention when it comes to dry eye?
So this is something I harp on, and really it doesn't get any kind of promotional sponsorship or attention, but really I go straight for the diet when I'm talking to these dry eye patients. A good book, resource book, is How Not to Die, which is a compilation of a whole bunch of different studies on nutrition and our diet. And, you know, one of the things, if you're going to get into dry eye disease treatment, I really think you have to look at nutrition and diet. So prevention. So there's a lot of foods that are inflammatory that are going to really upset and cause more inflammation to a patient with dry eye disease and meibomian gland dysfunction. So I try to get patients off of an inflammatory diet and get them onto a non-inflammatory diet, and get them to eat foods that are going to actually decrease the inflammation of their body, and that really will help the meibomian glands work better. But another thing that is often overlooked when we're talking about diet is that our diet is changing our gut microbiota. And if we want to have, and it's plenty of studies have shown that gut bacteria really affect overall systemic inflammation. And if you can change your diet, you can actually change your gut microbiota. I've never found that supplements will actually, probiotics will actually do anything to change the gut microbiota. It has to be done with diet, but you can really reduce the inflammation. The other thing is there's a lot of medicines that are prescribed by dry eye doctors or just eye doctors that is killing the gut microbiota. So the most common one is doxycycline. So we have patients that come into our dry eye clinic who have been on doxycycline for 10 years, and that just studies have shown that completely destroys the good microbiota of your gut that's decreasing inflammation. So as a short term, maybe doxy. I like low dose naltrexone better, and I did a lecture that's up on YouTube on that instead of doxycycline. But I would say, that is pretty much one of the number one things that you can do as an ounce of prevention before you even get into medications and IPL and any of those things. So I spend a lot of time talking to my patients about what a good diet is.
That is a really good starting point for anyone that is young and just kind of showing those initial signs of dry eye, or even maybe before they're showing signs of dry eye, just to educate patients. You mentioned that a number of your initial images you take at the beginning and then you don't take them again until treatments are complete. What images do you take along the way?
No, really none. I just make slit lamp observations. So for example, if a patient is getting IPL and Ophthalite, so I will document what their meibum looks like, what their lid margin looks like. Do they have scurf? Do they have collarettes? What the conjunctiva looks like. So those will be documented along the way in the exam form. And then at the end, then we'll go ahead and redo all of those pictures and meibography and bulbar redness and all of those non-invasive tear breakup time. So, for example, like I was saying before, they'll go through a series of IPLs and Ophthalite before we'll ever get those scans again. And these patients, there's that psychological component, and you have to be very careful into not depressing the patient by going, okay, we're going to do tear breakup time again. You just had one treatment, or you've been on CEQA for 3 weeks, and now we're going to get another tear breakup time. And then say it goes from 4 seconds to 3 seconds, or 4 seconds to 5 seconds. We're like, oh, it's worse. Oh no, I'm getting worse. And this weighs on the patient. So it's not doing you any good. It's not going to change your trajectory and how you're treating this patient. and it's not going. It can change how the patient views their treatment. I wrote a blog on the placebo effect, but people never think about the nocebo effect, which is the opposite of placebo, where uh, if a patient perceives something's not working, it won't work.
That's a really great point. Just along with the fact that your clinic's resources are, so valuable that if it's not going to, you know, be the information, right away that's as valuable to you, why not wait until the end?
Well, what also happens is that once you start getting dry eye patients, they'll start talking to their friends and other people, and with social media, you'll start getting more and more patients. And if you were to do this exam on every patient every time they came in, it would bog your clinic down, and you wouldn't be able to see as many patients and help as many patients. So you really start becoming good at time management so that you can get yourself out there and get these patients help. And if you don't, then your clinic will get bogged down. The techs will be unhappy. Scheduling will be unhappy. Sometimes, and we have this problem sometimes too, is that a patient will come in and they will want to ask a lot of questions and take up a lot of your time. And if you're bogging down a lot of your time with a lot of these testing, unnecessary testing, that takes away from that time. So, one of our problems that we're working on is first time patients that are coming in, now we're blocking out a good hour for them to go through their dry eye exam. So go through testing, exam, and then conversations with the doctor.
Perfect. Kind of on that subject of time management, what testing do you do yourself and what do you outsource to your techs?
So the mybography, non-invasive tear breakup time, the tear meniscus, the pictures. Sometimes I'll see the patient in the slit lamp, and then I'll actually want more pictures because I see something cool that maybe they didn't pick up on. But it's educating your techs too on what to look at when they're doing mybography, so that they go, oh, he always wants us to look at conjunctivalis. So if I see a patient that I think has conjunctivalis, maybe I should take a picture of him. So there's sometimes where I will see something on the slit lamp and I go, that's really interesting. I want to take a picture of it so that I could use it in a lecture or to educate the patient. So really, at the slit lamp, I don't do fluorescein anymore. I do lissamine. I like to see what's going on with the conjunctiva. And unless it's a study, that's basically the slit lamp exam. I can look at their tear film. I can look at the lipid layer. I can look at the redness. I can look at injection. I can look at all those things. And I know that with the Keratograph, the tech has already gotten a lot of that stuff documented as well.
Fantastic. You talked a lot about using the Keratograph images for patient education. How do you present treatment options to an asymptomatic patient?
Yeah, so I think a lot of asymptomatic patients don't really know about dry eye, so that when you start telling them, hey, when you're reading a book or you're on, the books are gone. When you're on your phone, when you're on your computer for long periods of time, does your eyes bother you? And it's just asking pinpointed questions, and then they'll say yes, and they'll yes, and they go, well, all those things that I'm describing to you, those are all signs of dry eye. And we need to treat this because it's an inflammatory disease. If you let that inflammation continue, what it'll start to do is it'll start to break down the glands even further, and then your mild disease will turn to moderate, and moderate will turn to severe.
Perfect. And I think we have time for one more question. and it's specifically about IPL from someone that's considering buying IPL. What specifically do you look for when considering a patient for IPL?
So that's where that Keratograph really comes in handy, because the only thing that I've ever seen to improve meibomian gland morphology and dropout is IPL, and I've tried everything. If there's something to be tried, I've tried it over the years. So if they have a change in morphology, and that grading scale, is a little bit arbitrary, but if you can look at that meibography and you can see that they have twisting of the glands, or they have dropout, or they have this sausaging, a lot of sausaging of the gland, those things. If I start seeing those things, it's very easy to talk to the patient about dry, show them that meibomian gland dysfunction in a picture, and say, look, we got to get these glands working. 30% of your glands are dropped out. We need to get those back, because what will happen is if we let this go, it'll turn to 40%, 50%, 70%. So that really is a good tipping point for patients to need an IPL. So usually I'll start out with something like Sequa. I'm starting to use Tyrvaya as well as a first line. And then if that's not doing it, like say they have meibomian glands that are pretty normal, but they still have this toothpaste-like secretion coming out of their gland, or you squeeze on their glands pre doing anything, and nothing is coming out, they're not producing any oil. I'll start off with either an anti-inflammatory or a Tyrvaya. I don't do plugging. I don't believe in artificial tears. I think artificial tears are doing more harm than good. If you look at the ingredients of a lot of these artificial tears, they have boric acid, which over time, boric acid will actually destroy the cell morphology, not only on the meibomian glands, but also on the conjunctiva. A lot of the things that we're using are cytotoxic. There's that paper showing tea tree oil is cytotoxic to the meibomian gland. So a lot of the things that were normally used, I don't use anymore. Now, a drop that I do use, and this can go in conjunction with a Sequa or Tyrvaya, is Optimel, which is out of Australia, which is a Manuka honey drop, which has been shown to be anti-inflammatory and great for patients with allergies. So instead of using an antihistamine that's going to dry the patient more, you're using this Optimel as your allergy drop. I did a presentation and also on YouTube on Optimel and how it can be used for allergy patients. So if those initial things aren't doing the trick, or if they have more meibomian gland morphology that I know is very dysfunctional, I will go to IPL.
Perfect. Thank you for that excellent answer. And I actually have a follow-up question based on your response to that, avoiding those treatments which are harmful to the eye in the long run, like tea tree oil. What then do you use to treat Demodex?
So IPL will kill Demodex. We've got a good study going with some doctors in China that have been able to keep Demodex alive away from the face and away from the eyelashes. They can keep them alive for 1 week. And showing IPL actually kills those Demodex. We know that IPL actually kills all microorganisms, so the Optolyte's a great treatment for that. And then the other thing that Demodex love to feed on is dry, dead skin. And that's usually why they go around the hair follicles. So we use a wipe called the Soothe Wipe, which you can get at Toyos online, which has hyaluronic complex, which moisturizes the skin of the lid margins and skin of the lids, and actually also is a good way to stop Demodex from overpopulating. You got to realize that you have this bacteria and these Demodex that actually are going to live on your skin, and they're part of the normal microbiota of your skin. So you don't want to destroy all of that, because there's some beneficial effects to having that there. But what will happen is, Demodex can move, and in these videos we show these Demodex, they can move around. So you're going to treat them, and this is a good reason to do IPL, from here to here, so that you can kill that Demodex that will actually, if you're just treating the lid margin, can come up and take the place of the Demodex that you got rid of.
Great, that makes a lot of sense. We have an immediate kind of follow-up question to that. How many sessions do you usually do with Demodex patients? One time, 4 sessions?
Yeah, it's usually a 4 treatment protocol. The more severe and the older the patient, the more treatments that they'll need. With the Optilite, you can do a treatment every 2 weeks. And that's one of the advantages of the Optilite as opposed to a first or second generation IPL system. And that's a whole nother lecture. But a one-time treatment is more for like a hordeolum or a new chalazion, however you want to define it. But yeah, if that would be more of a one-time treatment. But most of these, what we found in all the studies that we've ever done with IPL and meibomian gland dysfunction is that the first 2 treatments, you will get a small improvement, and then the third and fourth treatment, you get exponential improvement. So really, it's a 4 treatment protocol.
Perfect. Thank you so much for all of your answers to these questions tonight, and thank you so much for that presentation. I want to take a moment to shout out the Grizzlies and give a shout out to everyone in the audience. Thank you so much for joining us tonight. Again, Dr. Toyos makes himself very available if you have any additional questions, and I hope you all have a great night. Dr. Toyos, do you have any final words?
No, thanks. Thanks for taking time. I know you're all busy with your practices and stuff, but thanks for taking some time to get some education.